I will now turn the webinar over to Ms. Leanne Schlamm, Dr. Catherine Chrétien, and Dr. Todd Gleason. Ms. Schlamm is joining us from the Cincinnati VA as a nurse educator. Dr. Chrétien is from the Washington, D.C. VA Medical Center and is a faculty member at George Washington. And Dr. Todd Gleason is with the Uniformed Services University of the Health Sciences and the VA Medical Center in D.C. Dr. Gleason is also an active member of the U.S. Navy. Welcome to all of you.
Thank you. Hi, this is Leanne Schlamm, and as Anita described, I'm a nurse educator from the Cincinnati VA, and we'll begin by going over our objectives for today. We're going to talk about the conflicts and accompanying health concerns and the characteristics of each generation and how individuals may or may not ascribe to the general characteristics or health issues. And then we have case studies that will be presented later and apply the knowledge in a patient encounter. As a nurse educator and simulation specialist here at the Cincinnati VA, I worked with my medical media to come up with a timeline. And this is presented early on to our staff and nurses and to the bedside so that they can get a picture of who that they may come in contact and why does that make a difference when they're delivering the care to them. So I have, and thanks to the medical media specialist again for developing this timeline, and it just has the ages and the current year. And so I asked the staff, think about what military conflict could this person have been involved in. And then I apply it if it's in a simulation scenario. Of course, they have the age. Then they have to think about how do you develop your plan of care based on that patient's age and what their military conflict could have been. And then look at further on, how will the discharge be impacted? So it's just important as we have new employees coming into the VA, of understanding not only who their patients are, that they are veterans, but why does that make a difference in delivering the best care that we want to give them. So next will be Dr. Gleason. I'm passing the ball on to him, and he's going to describe furthermore. And please, as Anita said, if there's any questions, we will answer them at the end. Thank you very much.
Gleason. I appreciate everyone's time today. I thought we would start with a case from OIFIOEF, and this is a patient of mine. It's a 33-year-old Army Reserves Staff Sergeant who presented to clinic, returning from his third deployment to Afghanistan 4 months ago. While in Afghanistan, his Humvee drove over an improvised explosive device, and he was unconscious for a few minutes after the blast. He still has neck and back pain, for which he takes oxycodone and acetaminophen. In clinic, he's complaining of headaches, as well as intermittent ringing in the ears. And since going back to his civilian job, he finds he is forgetting important details and, quote, just cannot get anything done. He also cannot sleep. He cannot get out of his mind the experience of carrying his friend's body away from the Humvee blast area. And specifically, he keeps feeling the sensation of being poked by the broken femur that poked through the body bag. He tells you that he can only stop thinking about it after drinking a pint of vodka. So I think that frames, I think, for us a case which we'll follow up with at the end of my portion to kind of tie in some of the key medical conditions that we're seeing in our veterans from this generation, from OIF and OEF. To review these two areas of conflict, to remember as a group that our invasion of Iraq occurred in March 2003, and formally that conflict ended in December 2011. It was Operation Iraqi Freedom. It was renamed Operation New Dawn in 2010. Over 4,000 fatalities occurred in Iraq, with more than 32,000 of our U.S. troops wounded. In Afghanistan, Operation Enduring Freedom, that actually began October 2001 and continues today, with about half as many fatalities to date and over 16,000 wounded. Wounded includes here not only physical body injury, including amputations and other injuries, but also traumatic brain injury. So in total, 2.6 million service members have deployed in OAF and OEF, and nearly 1 million have deployed more than once. And to add to this, about 1.4 million of these service members have gotten out of the military since 2001. So the probability is there that these patients will be cared for across the United States in many different settings. So the prevalent conditions that we've seen in our veterans from OIF and OEF include what we've been calling the signature injury of these conflicts, traumatic brain injury, partly due to better battle medicine and protective gear. Up to 20% of our veterans from OIF, OEF have suffered TBI. Post-traumatic stress disorder is common, along with depression and suicidal ideation. Substance use disorders we will review as well. Other things I don't specifically review here are also common: hearing loss, sequelae of exposure to environmental toxins, endemic infectious diseases, which do include some of the more esoteric things that we haven't seen in the U.S., typically including Q fever and leishmaniasis. And chronic pain is also a prevalent condition in these vets, specifically musculoskeletal pain, for which patients take medication chronically. To look at traumatic brain injury, when we review all the battle injuries, the most common battle injury mechanism is blast waves. And in these vets, TBI accounts for up to 22% of casualties. If you look at mild, moderate to severe, mild to moderate TBI is as high as 10 to 20% of all OIF, OEF veterans. So importantly, as mild traumatic brain injury symptoms can emerge more distant from the time of injury, it's important for all providers to be aware of the common symptoms of mild TBI and to screen any OIF, OEF veteran for TBI. The symptoms are generally in 4 domains. Cognitive, so patients may complain of poor concentration, memory problems, might have difficulty completing tasks. Neurosensory, they may have paresthesias, visual problems, hearing problems, or they might have sensitivity to light. Physical symptoms include dizziness, headaches, vertigo, and nausea. And psychological symptoms, they might have difficulty sleeping, they might have anxiety or irritability. And the 2 references I have on this slide are fantastic references that I would encourage anyone to keep in your own PDF files. These are excellent references to review medical care of returning veterans. Looking at TBI some more, when we look at all TBI, most resolve within 1 to 3 months without any chronic neurologic problems. And looking at presentation, some TBIs can present months to years later. And in particular, if one of our soldiers has significant other injuries, TBI may not be recognized in the early months of their care for these other injuries. Moderate and severe TBI, unfortunately, usually do have significant long-term effects on cognitive function. So in the end, all providers really should screen veterans for TBI. This is from the Joint Department of Defense and VA Clinical Practice Guideline for TBI. And you'll see the questions correlate with a lot of the symptomatology that we've already discussed. And this is from a very nice pocket card that the VA has produced. And this is from the VA and DoD Clinical Practice Guideline for management of concussion or mild TBI. Now, mild TBI that you see on the classification here is synonymous with concussion, but you'll see that much of the diagnostic accessioning can happen early after the injury to determine how long was our patient, how long did they have loss of consciousness, for example. But this, I excerpted this from the military pocket card, which has everything you kind of need to know about diagnosis, classification, and management, including what symptoms to see, and then who do you refer your patient to for ongoing diagnosis and management. Within our patients with TBI, headache is far and away the single most common symptom, and you can treat headaches in the usual manner that you would otherwise. But it's important to note that you don't want to give medication to help the neurocognitive effects of TBI. And when you look for medications for headache or for pain or depression and anxiety, you have to be careful to not give any sedating medication because that will often worsen the TBI symptomatology. Post-TBI psychiatric symptoms usually benefit from a combined modality approach with psychotherapeutic, cognitive behavioral therapy, and pharmacologic treatment. Amputations are common, and this is partly due to improved battle gear where our veterans are surviving major trauma. Over, or nearly, 1,300 OIF veterans have survived major traumatic amputation. I think an area of work here is in the mental health, specifically of our amputees, and specifically, guidelines for, as providers, how can you specifically talk to the patient who has had an amputation, who is a veteran. What I've found in our experience is the response, the personal experience of an amputation is a very individual experience with different phases. Many of our returning veterans with amputations, I will say, want to get right back out there and return to their unit, and many want to stay in the military and continue service. Post-traumatic stress disorder and depression are also common in OIF. PTSD, when we screen for it, was seen in 25% who have deployed to Iraq or Afghanistan since 2001, and PTSD often coexists with other diagnoses. Depression, when we screened with the post-deployment health screen, was diagnosed in up to 13% of OIF combat soldiers. And when you look at all comers to the VA system, 17% of veterans seeking care have underlying depression. This is almost twice the general population rate. Suicidal ideation and substance use disorders, again, often go along with these diagnoses of PTSD and depression. As of August 2010, 260 service members had committed suicide while serving in Iraq and Afghanistan. And looking at the rate among OIF veterans enrolled in the VA in 2008, there were 43 suicides per 100,000 persons, compared with 12 per 100,000 the general population. Substance use disorders, one study, 2001 to 2009, showed that they were common. Alcohol and drug use disorders occurred in 10% of OIF and OEF veterans. And as Dr. Chrétien will go into, Vietnam veterans, this is actually a similar rate as seen in Vietnam veterans. When you look at substance use disorders, we see that they're 3 to 4.5 times more likely in veterans with PTSD or depression. These often go together. I mentioned environmental exposures, which is part of the military history pocket card as well, to discuss with the patient and to document whether they had exposure to sand, dust, particulate matter. Burn pits were very common practice in Iraq and Afghanistan, and still are ongoing in Afghanistan. And this is where, if there's not another disposal option available, all trash and human waste is burned in open air setting. And some of our veterans are complaining of symptoms that are not yet defined under a syndrome, but they're being followed to see if there's medical illness that can be attributable to this. Other exposures are depleted uranium. We have that in tank armor as well as some bullets. And there's a lot of noise and vibration exposure as well to OIF and OEF vets. So I alluded to the question of if there's symptomatology in my patient, and I'm not sure whether they fall into a specific diagnosis, we'll get a lot of information from the Millennium Cohort study. This is a large joint VA-DoD effort where over 77,000 U.S. service members were surveyed in 2001-2003 and followed prospectively to accession their health concerns and to look for any patterns. But specifically, this includes all the exposures that we've talked heretofore. But already from this study, we've seen some important information. So deployment in OIF and OEF is associated with higher rates of smoking, smoking initiation, as well as recidivism. And the younger veterans in OIF, OEF, the rate is as high as 40% compared to 20% in non-veterans. Hypertension is also more common in our vets. Deployed individuals who had multiple combat exposures were 1.33 times more likely to have hypertension than those who deployed but did not engage in combat. And we also see in our OIF, OEF vets who have any mental health diagnoses, we see elevated rates of reversible cardiovascular risk factors, tobacco use, hypertension, dyslipidemia, obesity, and diabetes. So to follow up on our case from Afghanistan, what I think we see here is probable mild traumatic brain injury, as well as PTSD and substance use. What's important to realize in a lot of our patients, the PTSD symptoms precede the substance use. That is, the veterans are often using substances as self-medication. So our patient is plugged into a multidisciplinary team with a case manager, social work, neurology, as well as ENT for his tinnitus, and with his primary care physician. So with that, I'm going to move on to Dr. Chrétien.
Hello, everyone. I'm Catherine Chrétien. I'm the Medicine Clerkship Site Director at the VA in D.C., and I've been here for 10 years. I'm also the Chief of the Hospitalist Section. And I'm also a military spouse. My husband is an active duty Navy medical officer and recently spent a year in Afghanistan. So we're on to case 2. This is a 65-year-old African-American man who's admitted to your hospital service for a second cycle of chemotherapy for non-Hodgkin's lymphoma. He has a history of hypertension, chronic renal insufficiency, hepatitis C, and substance abuse, which has been in remission for 10 years. And you see on his chart that he was exposed to Agent Orange while serving in Vietnam. The Vietnam War occurred from August 4th, 1964 to January 27th, 1973, about 10 years. And some stats of that war: there were over 8,744,000 who served. 3 million of those were deployed to Southeast Asia. There were 47,424 battle deaths, 153,000 wounded, 238 medals of honor, and over 7 million living veterans. One veteran of the Vietnam War, Tom Hagel, says, "When we think of wars, whether it's Vietnam or any other war, we think of it as a unitary subject, but there are millions of Vietnam wars." It's important to keep in mind when we think of any service member who has served in war, whether in OEF or Vietnam or the Korean War, that it's all an individual experience. Vietnam turned out to be a protracted guerrilla-style conflict, and back at home there was rising American public opposition of this war. It really strained the relationship between the government, the people, and the military. And as you recall, young men were subject to be drafted into the war, and this increased the anti-war sentiment and resentment against the government. The draft ended in 1973 when the U.S. converted to an all-volunteer military. And Vietnam was also the first time that America failed to welcome its veterans back as heroes. And many said when they came back into the airport, people were spat upon, very hostile environment. And this really magnified the stress they experienced associated with their wartime experience. They also had lack of unit cohesiveness, as many veterans went over to Vietnam as individuals and served for a year and then left when their tour was completed. So they might be in active combat one day, and the next they were headed on a plane back to this hostile civilian environment. So many reported lots of stress and being uncomfortable wearing their uniforms in public. Along with the general health risks from wartime service, Vietnam veterans have two unique health risks, and that's related to environmental exposures as well as bloodborne exposures, Agent Orange, and hepatitis C. So we'll start with Agent Orange. And Agent Orange is actually a blend of tactical herbicides. It wasn't commercial herbicide, but one blended by the U.S. military. It was sprayed between 1962 and 1971 during the Vietnam War to remove trees and dense foliage that provided enemy cover. More than 19 million gallons of various rainbow herbicide combinations were sprayed, but Agent Orange was the most common one that was used. And its name was actually came from the 55-gallon drums that held them. They had this orange identifying stripe on them, so known as Agent Orange. Heavily sprayed areas included the forests near the demarcation zone, the forest at the junction of the borders with Cambodia, Laos, and South Vietnam, as well as other areas in that region. And the dioxin TCDD was an unwanted byproduct of this production of the herbicide. And dioxins, as you may know, are pollutants that are released into the environment, and TCDD is the most toxic of the dioxins and is now classified as a human carcinogen by the Environmental Protection Agency. The VA recognizes certain conditions which are presumed to be related to their service in Vietnam and for this exposure, and they're seen on the slide. When you think about asking for exposures, regardless of the military conflict, think about asking the what's, how's, where's, when's, and who's. And this is taken from the military pocket card that Todd mentioned as well. So what were you exposed to? How long was this exposure? Are you concerned about the exposure? Where were you exposed? When were you exposed? And who else might have been affected? I wanted to mention the Agent Orange Registry health exam that the VA offers, which is free to eligible veterans and no co-payment is required. You don't have to be enrolled in the VA health system, but it helps to alert veterans about possible long-term health problems that may be related to Agent Orange exposure. And it's based on veterans' recollection of service, not their actual military records. It's not going to confirm their exposure, but they can receive lots of information and be added to this registry, which helps us better understand what could be caused by Agent Orange exposure. Of note, family members are not eligible for this health exam. And then hepatitis C is another unique health risk, and it's the most common bloodborne infection in the U.S., usually resulting in chronic hepatitis. Vietnam veterans may have received transfusions, and this is before screening of hepatitis C occurred, which started in 1992. Or they may have been exposed to infected bloods or fluids in their wartime experience. As Todd mentioned, there's also a high rate of substance abuse due to the availability of cheap drugs in the very stressful environment. So some key questions to ask are, have you ever had a blood transfusion? And have you ever injected drugs such as heroin or cocaine? So follow up on case 2, your patient undergoes an uneventful chemotherapy course. He's getting ready for hospital discharge. He thanks you for your attentive care and chats with you about medical school. You ask him, what's one thing you think my colleagues should know about Vietnam veterans? He says that we fought in a war too. It didn't feel that way when we got back. We were spit on in the airport. We were called baby killers, but we fought in a war. The next case is a mini case. It's a 46-year-old Caucasian man who's your next patient in clinic. He served in the Army in Desert Shield and Desert Storm in 1990 to 1991. He carries the diagnoses of chronic fatigue syndrome, irritable bowel syndrome, migraines, and fibromyalgia. He takes over 20 medications and inhalers for these conditions. He reports feeling wiped out, both physically and mentally, after exercising. The Gulf War, also called Desert Shield or Desert Storm, took place over 1990 to 1991. Total U.S. service members serving during that time was over 2 million. 690,000 were deployed to the Gulf. There were only 148 battle deaths, but 467 non-mortal woundings, and there are over 2 million living veterans who served during that conflict. From the VA perspective, Gulf War service includes both Desert Storm and Desert Shield, as well as through OIF and Operation New Dawn as well, so up to 2011. And this is the area that you see of included regions. The unique health risks are similar and have overlap to what Todd presented in Operation Iraqi Freedom, and include chemical or biologic agents, depleted uranium, dermatologic issues, exposure to smoke, immunizations, infectious diseases, and reproductive health issues. And a prominent condition affecting Gulf War veterans is a cluster of medically unexplained chronic symptoms. It can include chronic fatigue syndrome, fibromyalgia, functional GI disorders, and other diagnosed chronic illnesses. We're still trying to understand this condition. What are the causes, the effects on the brain and the body? There seems to be prominent symptoms following exercise, but still trying to understand it. But important to keep in mind when you're seeing these veterans. The VA provides also a Gulf War Registry health exam, which, similar to the Agent Orange Registry health exam, is free to eligible veterans without a copay. It is not a disability compensation exam. It's not required for VA benefits, and you don't have to be enrolled in VA's healthcare system. But it does help VA better understand these problems and respond to them as well. And Again, it's based on the veteran's recollection of service, not military records. And they can receive additional registry exams if new problems develop over time. Families are not eligible as well. So we mentioned many different references and resources and listed them here and encourage you to go to them for further questions. We only covered some of the possible conditions, but hope you have a better understanding of how these different generational issues result in what patients might present with and what you'd see in clinic or in the hospital setting. So we have time now to take any questions that you have, and I'll give it back to our host.
Thank you so much for an informative discussion about the various health concerns of the generations of veterans in our healthcare system. So there are a couple of comments and questions that we'd like your response today, if you don't mind, presenters. The first is that a person has related that their experience has been people on active duty are hesitant to consult doctors about some of the emotional difficulties they might present with because of concerns of privacy, and offered an idea of a personal jump drive of information that a patient might share with their doctor, and it'd be sort of a co-shared source for both the person and their physician. Would you care to react to this idea and maybe delve into a little bit more about the different emotional problems that our veterans face and how we might work with them in addressing privacy as well?
So this is Catherine. I definitely think that is a major issue, is privacy, as well as just the stigma of admitting to you're having those problems and working on having that be less of a stigmatizing thing, and people are worried about it affecting their promotion and their careers if they admit to having emotional problems or mental health issues. In terms of privacy, I know that DoD and VA is working on having like a seamless transition between active duty and VA service to keep that record intact, and that's being developed. But having a way to share that with civilian providers would be very important as well. I don't know if Todd has any insights on that.
Yeah, I think thanks, Dr. Goodwin, for those great comments. And thoughts. I like the idea of sort of a portable health record to, allow for continuity of the record between civilian, DoD, and VA, spheres of care. I do know, we have called it a suicide epidemic with the problem of suicide in both active duty and veterans, and this. There has been a joint, VA-DoD suicide awareness campaign that started last September, and it basically encourages everyone concerned about suicide in active duty or veterans to engage in suicide prevention by calling the VA suicide prevention hotline. And I know that there are hundreds more mental health providers who have been hired because of the mental health issues on both sides, DoD and VA. One thing that it's such a big deal with the stigma of getting mental health care, and when one is active duty, there's this big worry that it's going to shorten your active duty career. Will you make it to retirement? Will you make rank? So there is a nice resource, militaryOneSource.mil is a website that anyone can go to. On there's a phone number, and it's manned 24 hours a day, all days of the year. And when you make that phone call, you talk to someone who has a degree in social work and in counseling. And at a minimum, any question a patient, family member, or a provider, civilian or federal, could that question, could start with a phone call to Military OneSource. But specifically, I know active duty through Military OneSource, can get connected to a mental health professional, and it's off the record. So it is mental health care access, and those visits are actually, not in the health record. And this was a response to directly to the stigma and our individuals not wanting to get care. And I think this was an excellent move to allow access to care. But I think Dr. Goodwin brings up a good point that it would be ideal to be able to have all those records kind of owned by the patient to allow for any providers, wherever that person is seen, to be aware of everything that's gone on with that patient and to help them in the best way. And I will give another nod to those articles, Dr. Spellman et al. And Dr. Sessons and Dr. Jackson, in post-deployment care for returning combat veterans. One of the clinical pearls in these articles is to, one of the first things you have to do as a provider is to address barriers to care. And the biggest piece of that is to negotiate, and destigmatize mental health care, because it seems to be in their individual makeup that you're in the military, you are meant to be strong, and it is a weakness to be anything other than that, and to get care for any mental health issues. And so one of the first conversations that you have as a provider is to ask the questions and to explicitly address and destigmatize that. So I think just, to make sure that the resources are out there, it's militaryonesource.mil for active duty, and then there is the VA DoD Suicide Awareness Campaign, and that's really through that VA suicide prevention hotline. But I will give a nod to it's a huge problem. Despite aggressive efforts that are ongoing right now to address it, it is still ongoing at high rates.
Right, and we will be covering the topic of suicide prevention and awareness later on this week. So join in for that webinar series, or part of the webinar series. As we think about that, though, have there been any studies or generational differences in terms of how veterans perceive themselves? That's a question from Dr. Hemmer at USIS. And he writes, in other words, are there subcultures within the veterans culture that we should go beyond, particularly if we think about it in terms of generational differences? Would someone on our panel like to address that?
This is Catherine. I'm not aware of such a study. It may be out there. I'm not aware of it, but just thinking about the big difference between those populations that were drafted versus not, I think creates a definite difference in the culture of these veterans, and that whether they chose, the service versus they were drafted, I think makes a big difference.
And this is Leanne. I know anecdotally for nurses and staff at the bedside, they have verbalized they see a difference when, they're sharing a room, two patients of different either generation and military exposures, of the difference that they see, and especially like in our CLCs, our community living centers. But I don't know of any research on that either.
I'd agree with that anecdotal observation, and you definitely see it when they share a room, and that some of the veterans from the other older generations really enjoy that camaraderie. And I did a study with a resident a few years ago that was looking at shared rooms and the veterans' preferences, and it was the older veterans that enjoyed that. They help each other. They will tell you where the other person is, and like support each other. They have a great interest, and some really enjoy spending time together with their roommate, versus the newer veterans seem to value the privacy much more and less about that camaraderie.
Great, thank you for those answers and the observations that you offer. We have another question that's shifting gears just a little bit. What are the reproductive health issues identified in the Gulf War veteran population?
This is Todd. That's a great question. I don't specifically, know the answer, but I have seen, data fields within the Gulf War questions in terms of the study Catherine was discussing for the Gulf War syndrome, looking at fertility issues of men and women. But I'm sorry that I don't know specific answer.
This is Leanne. I don't have a specific answer, but I know within the VA, our women's health care has increased significantly. And from an education standpoint, to make sure the providers kind of have an update on their knowledge of what are the possibilities and what they may see on doing exams and the questions related to that.
Great, thank you both. One other point that maybe you could speak to as a question is, so you all have your various affiliations with the VA, with USIS. You're sort of entrenched in working with veterans and with current service members. What are the takeaways from your presentation for the civilian provider who is not maybe in that population day in and day out, but this information, what are the key points you would like people to take away from this?
Yeah, if I could start, Catherine, Leanne, I think, I'm in a unique position to work at both Walter Reed on active duty folks, and then also I have the privilege and honor to see patients over at the DCVA down the road. And I have seen patients in a longitudinal fashion. So I've seen patients who, from OIFIOEF, who have had traumatic wound infections, for example, and I got to participate in their care when they were active duty, and then also when they were a veteran. And I also do ID, and I have HIV patients who were active duty, and now I'm caring for them at the VA clinic. I think the best thing to take away is to be sure to ask the questions that we've described and that are on the military history pocket card, and to just take a military history that opens up so much. And so once you start asking within the psychosocial history, within the social history, were they ever in the military? What did you do in the military? How has that affected you? These simple questions, I find, are really dramatic in terms of their power to forge a bond between the patient and yourself as the provider. Not all the time have they gotten to share their story, and they appreciate that attention, but it does lead to not only a better relationship, but more specific questions on any exposures or risks. And so, I think that would be the biggest takeaway. One thing that we, DOD and VA are actively working on is that transition of care from active duty to getting care in the VA, just so everyone is aware of what's going on. There's active work on increased communication between the electronic medical records and also between the providers to make sure that once a patient leaves active duty, they're getting great care. They're getting assessed for any exposures before they leave the military. And then on their intake with the VA, many of these questions and exams are repeated to make sure no one's missed. But this is an area of active attention, particularly with these recent conflicts. But, I think to summarize that, I would just make sure that you can ask the question and discuss their military history. It really helps that bond between you and the patient.
I agree with Todd that asking the questions is the most important, and to keep in mind that you will see veterans regardless of what location you're practicing in, and that many will seek care outside of the military health system and the VA healthcare system, that it's important to stay up to date with developments in these areas, and the continuing medical education should include this kind of up-to-date knowledge, to know the resources and where to go for more information. And lastly, to keep in mind that everyone's experience is individual, even though we're talking about generational differences and making some generalizations, that every individual experiences war and their service differently, and you won't know until you ask them.
And I too agree with what Todd and Catherine have both said, and that I also carried on into the nursing schools to the nursing students that I interact with, of telling them, have you ever asked your patient, are you a veteran? And how that, if we're doing holistic care, and it's okay to ask, and we should know who we are caring for all of our patients, and understanding if they are a veteran, what else does that mean based on their individuality.
Great. Do we have any further questions from our participants in the audience? Great. Well, on behalf of the Joining Forces team here at AAMC, we'd like to say thank you to our three presenters for sharing their expertise on this topic today. As Anita mentioned, tomorrow's webinar, titled Suicide Symptoms and Prevention, will further discuss risk factors and warning signs associated with suicidal behavior and suicide prevention efforts with veterans and service members.